Welcome back. Today we're breaking down asthma, a must-know for exams and real-life clinics. Asthma is a chronic inflammatory disorder of the airways, making them hypersensitive and prone to flare-ups. Picture your airways as tubes that get inflamed, tighten up, and fill with mucus, making it tough to breathe. It's one of the most common chronic diseases, especially in kids, and a major cause of missed school and work. The key feature asthma is reversible. Between attacks, lung function can return to normal. During an attack, airways narrow, but with the right meds, they open back up. This reversibility is what sets asthma apart from other lung diseases like COPD. Remember, inflammation, bronchoconstriction, and mucus are the asthma triad. Let's dive deeper into what's happening inside those airways. Think of your airways as sensitive pipes. In asthma, they overreact to triggers, causing inflammation, muscle tightening, and mucus buildup. Immune cells release chemicals like histamine and leukotrienes, leading to swelling, constriction, and sticky mucus. Imagine a tunnel during rush hour. Inflammation narrows the lanes, bronchoconstriction squeezes them, and mucus clogs everything. Air gets trapped. Triggers vary by person, but common ones include media group, visual list or icons of common asthma triggers, medical animation of triggers affecting airways @stock distribute _equally, allergens, pollen, dust mites, pets, infections, exercise, cold air, smoke, stress, certain medications, and even foods with sulfites. Use the mnemonic allergens to remember. Allergens, lungs, infections, laughing, crying, environment, running, GERD, emotional stress, NSAIDs, sulfites. Identifying and avoiding triggers is crucial for asthma control. Ask patients about when and where symptoms flare up. This detective work is key. For example, symptoms worse in spring? Think pollen, nighttime cough, maybe dust mites or reflux. Patient education on triggers is as important as medication. Empower patients to control their environment. Avoiding triggers can prevent attacks. Let's move on to what asthma looks like in real life. Asthma's classic symptoms: cough often at night, wheeze, that whistling sound, and shortness of breath. Symptoms are variable. Fine one day, flaring the next, often after a trigger. Severe attacks: look for use of neck muscles to breathe, trouble speaking, and chest tightness. Diagnosis starts with spirometry. Patients blow into a machine to measure lung function. Key finding: FEV1/FVC ratio less than 0.7, showing obstruction. The hallmark: reversibility. After a bronchodilator, FEV1 improves by at least 12% and 200 ml. This confirms asthma and distinguishes it from COPD. At home, patients can use a peak flow meter to monitor their lung function daily. Recognizing patterns helps prevent severe attacks. Now, let's talk treatment. Asthma treatment follows a stepwise approach. Start low, step up if needed, step down if controlled. Two main medication types: relievers, quick relief like albuterol SABA, and controllers, daily, like inhaled corticosteroids ICS. For mild cases, a reliever as needed may be enough, but most guidelines now recommend starting with a low-dose ICS or ICS formoterol as needed. If symptoms persist, step up to a combination ICS-LABA, long-acting beta agonist. For severe cases, increase doses or add LAMA, long-acting muscarinic antagonist, or biologics. Non-drug management: teach inhaler technique, advise on trigger avoidance, encourage smoking cessation, healthy weight, and vaccinations. Every patient needs a written asthma action plan: what to do daily, during flares, and when to seek help. Patient education is as vital as medication. Empower patients to manage their asthma. Review and adjust treatment regularly. The goal: control symptoms with the least medication. Let's wrap up with key exam tips. For exams, remember the asthma triad: inflammation, intermittent obstruction, and increased responsiveness. Classic symptoms: wheeze, cough, especially at night, and shortness of breath. Diagnosis: spirometry with reversible obstruction. FEV1 improves by 12% and 200 ml after bronchodilator. Management stepwise, starting with relievers, then adding controllers and escalating as needed. Mnemonic: SILAS, SABA ICS LABA add-ons, specialist care. Always check inhaler technique. Many use it wrong. Ask about symptom patterns and family history. Asthma, allergies, eczema. Patient education, trigger avoidance, and a written action plan are essential. Asthma is chronic but reversible. Good management changes lives. Study smart and you'll ace both exams and real-world care.